There are different complications that can arise in patients with diabetes, which includes the hyperosmolar hyperglycemic state, which is usually seen in patients with type 2 diabetes mellitus, where there would be no ketoacidosis, but then the glucose level would be more than 1000 milligram per deciliter, versus diabetic ketoacidosis, which is usually seen in type 1 diabetes mellitus. Glucose is less than 800 milligram per deciliter, but then there is metabolic acidosis with elevated anion gap due to the increase in the level of ketone bodies. So just keep that in mind. Diabetic ketoacidosis is more commonly seen in patients with type 1 diabetes mellitus, and this is due to the complete lack of insulin in these patients, because there is autoimmune destruction of the beta cells in the pancreas, and so there won't be any insulin production. Versus type 2 diabetes mellitus, where there is insulin insensitivity. So there is insulin which prevents development of the ketoacidosis in patients with type 2 diabetes mellitus. But since the insulin is not effective enough, these patients can develop hyperosmolar hyperglycemic state. Now, I would also like you to know that there are factors that can exacerbate diabetic ketoacidosis in patients with type 1 diabetes mellitus, and these include, for instance, the poor glycemic control. So if these patients do not take the insulin on time, and then there is poor glycemic control, therefore there would be increased risk of diabetic ketoacidosis. So number one is poor glucose control. The second factor could be trauma or stress. And then finally, infection like urinary tract infection or pneumonia can cause exacerbation of diabetic ketoacidosis. Now, ketones are being produced from the acetyl coenzyme A, so fatty acids are being broken down by beta oxidation to acetyl coenzyme A, which normally enters the Krebs cycle. But once there is low level of insulin, like in patients with type 1 diabetes mellitus, then the acetyl coenzyme A will enter the ketogenesis pathway, as a consequence of which there would be production of the ketone bodies, which includes the acetoacetate, acetone, as well as the beta-hydroxybutyrate. Now, I would like you to note that the beta-hydroxybutyrate is the main form of the ketones that is seen in patients with diabetic ketoacidosis or alcoholic ketoacidosis. And this form of ketone can be detected by direct measurement from the serum, versus the other forms, which is the acetoacetate and acetone, which are detected by the urine dipstick, which uses the nitroprusside as a dipstick that detects acetoacetate and acetone, but it does not detect the beta-hydroxybutyrate. So just keep that in mind. If you want to detect the beta-hydroxybutyrate, which is the predominant form of the ketone bodies in patients with DKA, then you will have to measure the serum levels. If you use the conventional urine screening test, then it would only detect the acetoacetate and acetone. And then one last point I would like to mention here is that patients with DKA present with the fruity breath odor, and the reason for that is that the acetone that is produced is being present in the breath, as a consequence of which it will have a fruity odor. Now, as I mentioned earlier, patients with DKA present with metabolic acidosis due to the presence of the ketone bodies, but then there is also elevated anion gap. So anion gap is calculated by subtracting chloride plus bicarbonate from sodium. The expected value that you should get is about 8 to 12. In patients that have elevated anion gap, the level is more than 12. For instance, in patients that have diabetic ketoacidosis. Now let me ask you a question. Do you know, besides diabetic ketoacidosis, what other conditions cause metabolic acidosis with elevated anion gap? And the memory aid for that is mud piles, or the other one is impulsed, which stands for iron, methanol, paraldehyde, uremia, lactic acidosis, salicylates like aspirin, which causes late metabolic acidosis, ethylene glycol, as well as the diabetic ketoacidosis. So just keep that in mind, that patients with DKA have metabolic acidosis with elevated anion gap. The other presentation in these patients is Kussmaul breathing, where there would be rapid and deep breath. And the reason for that is that since there is metabolic acidosis, the body tries to increase the respiratory rate by rapid and deep breathing to help bring up the pH. So since there is too much acid from the ketoacidosis, there is low level of pH in these patients. And so by increasing respiration via Kussmaul breathing, the goal is to increase the pH. So there would be compensatory mechanisms by Kussmaul breathing. And then the other symptoms that you see in these patients include, for instance, nausea, vomiting, abdominal pain, delirium, dehydration, as well as the fruity breath odor, which I just discussed earlier with you, which is due to the presence of the acetone. Now, in terms of the treatment for diabetic ketoacidosis and hyperosmolar hyperglycemic state is mostly similar, and that is you will have to correct by providing fluids. Since these patients have hypovolemia, you will have to provide fluids. Since they also have diuresis because of extra glucose in the blood, which causes hyperglycemic diuresis, there is also loss of electrolytes. So you will have to compensate for the loss of electrolytes in these patients as well. And then finally, you will have to compensate for hyperglycemia by providing insulin. So the treatment is usually directed at providing fluids, correcting for electrolytes, and providing insulin. So as I mentioned, fluid replacement, you can do that by the IV saline. So you can use the normal IV saline, which is 0.9% sodium chloride. And then if the sugar in these patients, in patients with DKA, sugar drops less than 200, then you will have to add dextrose to the IV saline to prevent the further drop in the glucose levels. Now, you should also provide the IV insulin to help resolve the ketoacidosis, and ketoacidosis is basically considered resolved when the anion gap drops below 12. So you will have to continue the insulin infusion until the anion gap is less than 12 and the patient is alert and able to eat. And then finally, you will have to provide potassium replacement. Now, the reason you have to provide potassium replacement is that acidosis causes shifting of potassium from inside the cell to the extracellular space. So now there is too much potassium in the extracellular space. At the same time, there is hyperglycemia, which causes diuresis, and so therefore potassium as well as sodium will be lost in the urine. So much potassium will be lost in patients with DKA, and this potassium is coming from the intracellular stores. Now, if you measure the potassium, it could be normal or even hyperkalemia in patients with DKA. And the reason for that, again, is that potassium has shifted from the intracellular space to the serum. So when you provide these patients with the insulin, insulin causes shifting of the potassium from extracellular space back to the intracellular space. So that's the time that you will develop severe hypokalemia. And so therefore, you will have to provide potassium in patients that have DKA. And so usually you will have to start providing potassium once the potassium of the serum drops less than 5.3 milliequivalent per liter. So again, just to summarize, these patients will have elevated glucose in the serum. So they would be hyperglycemic. There would be elevated H+ and low HCO3. So there would be metabolic acidosis with elevated anion gap due to the ketones that are present, and then there may be hyperkalemia or normal potassium. But once you provide these patients with the insulin, it causes shifting of the potassium into the intracellular space, and that's the time you will develop hypokalemia. And so that's why, besides the fluid replacement and insulin, you will have to provide also with potassium replacement. And so besides diabetic ketoacidosis, there are other forms of ketoacidosis, which includes the fasting ketosis. So hepatic generation of ketone bodies is normally seen in patients that undergo fasting for more than 12 hours, and this is a normal physiological state. And then alcoholic patients can also develop ketoacidosis. So what happens is that ethanol can be oxidized by the hepatocytes into the acetaldehyde, and then later it will be converted into the acetic acid. So for these conversions, what happens is that the NAD+ will be converted into the NADH. as a consequence of which the NADH ratio will rise compared to the NAD+. So in patients with acute alcohol intake, acetone, which is the byproduct of the ethanol as well as free radicals, will damage the mitochondria, and what happens is that there would be decreased mitochondrial fatty acid beta oxidation, as a consequence of which there would be liver steatosis. So these patients will develop fatty liver. And then, as I just discussed, there would be elevated NADH to NAD+ ratio, which causes decreased gluconeogenesis, as a consequence of which alcoholic patients can develop hypoglycemia. And then there is also conversion of acetoacetic acid into beta-hydroxybutyric acid. So as I just discussed earlier, there are different forms of ketone bodies. Now, conversion of the acetoacetate into beta-hydroxybutyrate will cause conversion of NADH to NAD+. Now, since in patients that are alcoholic, there is too much NADH, therefore there would be favor of conversion of acetoacetate into beta-hydroxybutyrate to increase the production of NAD+. So therefore, there would be more beta-hydroxybutyrate in patients that are alcoholic. And the reason I'm discussing that is that there is diagnostic implications for that, and it's that in alcoholic ketoacidosis, if you use the urine dipstick, it won't detect it. So there could be a false negative results in patients that are alcoholic ketoacidosis. So that's why it's important that you measure the serum beta-hydroxybutyric acid directly rather than using the urine screening test, because urine screening test does not detect the beta-hydroxybutyrate. And then lastly, I would like to discuss why these patients develop ketoacidosis. So while normally patients, while they're drinking alcohol, can develop some form of ketoacidosis, when they withdraw, that's the time that ketoacidosis gets worse. And it's due to the decrease in the level of ethanol, which causes an increase in norepinephrine and cortisol. And so these hormones, what they do is that they increase the lipolysis, as a consequence of which they can exacerbate the ketoacidosis. And that concludes our discussion.